Medical nutritional therapy of liver diseases. There is no standard diet of liver diseases because of many factors, among them the type of the liver disease, the stage of the liver disease, and other medical disorder. The best meal pattern for a patient with liver disease is to have multiple small meals throughout the day. Acute liver diseases are classified into three types: the acute hepatitis, fulminant hepatitis, and acute cholestasis. IV fluid is reserved for patients with excessive nausea and vomiting. Alcohol should be avoided in a patient with acute hepatitis at least for 6 months following the recovery. In fulminant hepatitis, there is hypercatabolism. Therefore, infusion of amino acids and glucose mixture is supplied. In acute cholestasis, there is no need for a nutritional supplementation except for parenteral vitamin K to correct the prothrombin time prior to procedure. Causes of malnutrition in chronic liver diseases are variable, like anorexia, steatorrhea, medication-induced losses, restricted diet, and other complications. The caloric requirement for a patient with chronic liver disease is 35 to 45 kilocalories per kg per day. However, excess calories should be avoided. Multiple small meals with a late bedtime meal, which has been shown to reduce the need for gluconeogenesis and conserve protein and nitrogen balance after an overnight fast, and will prevent protein breakdown. Lipid emulsion are well tolerated in patients with cirrhosis. Fat makes food tastier, and it eases the absorption of many fat-soluble vitamins as vitamin A, D, E, and K. Branched-chain amino acids do not worsen encephalopathy, and it is safely used to maintain an adequate protein intake in subjects at risk of altered mental status. Vitamins must pass through the liver to be metabolized, so if taken in excess, they can cause serious health problems in patients with chronic liver diseases. Calcium supplement is of importance for patients with chronic liver diseases because they are at risk of developing osteoporosis. Excess iron ingestion, whether in the form of food or supplements, is stored in body tissues primarily in the liver, so it is most susceptible to iron toxicity, and it will depend upon the stage of liver damage. Zinc improves glucose disposal in patients with cirrhosis. It also inhibits the hepatic inflammation and hepatic fibrosis, and it lowers the cumulative incidence of hepatic cell carcinoma in patients with hepatitis C virus infection. Decompensated liver diseases include encephalopathy and ascites. The diet modification of encephalopathy includes the protein, which is shown that the vegetal protein is better tolerated in patients with chronic liver diseases, and then the milk, and then the meat. The supplementation of 600 micrograms of zinc per day improves encephalopathy. Now we have diet as a cause of liver disease, and we will talk about two subjects: the obesity as cause of liver disease and hypervitaminosis A as a cause of liver disease. Obesity is associated with the development of parenchymal liver damage, that is the fatty liver disease, and also the formation of gallstones. Fatty liver is not related to the degree of obesity, but occasionally is preceded by a short period of weight loss. Usually, it is a mildly, slowly progressive lesion, but it could progress to cirrhosis. However, it is reversible and it will goes to near normal histology in patients who achieve and maintain substantial weight reduction to normal ranges.